Good morning, Aaron.
Hello, morning. Good morning, Steve. Okay.
I think you're feeling better.
Nah, that's great. Just a second, I'll just build you.
You look a bit feverish
How do you know that?
because you told me you had COVID.
Oh, thank you, thank you. I forgot about that. Yeah, everyone in Oxford.
Everyone's gone down with it, I think.
There's only one. I think.
Morning, Naren.
Morning, Dr. Boop. How are you? I'll just get my. Hello, Alan. Hello, Dr. Cohen. You okay? Great, thanks. Dr. Cohen, can I introduce Dr. Stephen Lois? Dr. Stephen Lois, can I introduce Dr. Cohen? Dr. Cohen is the head of Pediatric Neurosurgery at Johns Hopkins in Baltimore, and Dr. Stephen Lois is one of our senior pediatric oncologists in Bristol.
Well, a virtual good morning.
Yes, indeed. Well, it's morning here, and what is it with you? Middle of the night?
Morning, 7 o'clock.
When Aaron was working with us, we were amazed at his links with the entire world. Actually, I think we think you're the most connected individual in the world.
Thank you.
Yes.
Good.
Aaron, which did you want me to introduce? I think Eric is talking at
Yes, Eric, and then the two neuro-oncologists at 2, if you could.
Okay, so Dr. Kadumi and Dr. Moreira as well.
Yeah.
Okay. I can't find the timetable for today, actually.
Oh, the timetable is, I kept it not completely published because, with these webinar meetings, things sometimes, a bit fluid. But the running order is Dr. Eric Bouffet, and then Dr. Al Cohen, and then half an hour for Dr. Kudomi and Dr. Moira.
Okay. I'm happy to do those three.
Thank you.
And will you introduce Dr. Cohen?
Yes, absolutely.
Okay. Eric's title, I suggested a title to you originally.
Yes. So reducing tumor burden.
Reducing tumor burden, or the burden of
reducing the burden of burden for radiotherapy, isn't it? The one that you suggested.
Okay. Trying to reduce the effect, the adverse effects of radiotherapy in children.
Yeah. Hello, Meta. How are you?
Fine, thank you. You?
Thank you very much. Thanks for being with us, Meta. I really appreciate that. Good. Dr. Eric Bouffet is here. Great, thanks.
Hey, Eric.
Hi, Steve. We need to talk.
We do, but maybe not online.
I will contact you. I'm busy. I'm finishing service, but then the planning is.
I'm planning my cycle ride.
Dr. Bouffet, just not that you know all the people here. Dr. Alan Cohen, the head of pediatric neurosurgery from Johns Hopkins, Baltimore.
Hi, Alan.
I'm sure you know Professor Bouffet from Toronto. And we have got Dr. Meta Jorgensen from Great Ormond Street Neuro-Oncology. Thank you, Meta. And then we have got Dr. Dieter Klaas from Magdeburg in Germany. Hello, Dieter. Hi.
So I will put the light a bit better because nobody sees. Maybe you see my face a bit more.
Yes, we can clearly see that. Dr. Bouffet, you are happy for the lecture? No problem. You are happy for the lecture to be recorded, Dr. Bouffet?
Yeah, no
Brilliant.
problem.
Excellent, thank you. Excellent. So we have got a couple of more minutes. And then you have got another meeting, Dr. Bouffet, later on today?
Not today, tomorrow.
Tomorrow, okay.
I'm in the Middle East tomorrow, in Beirut.
So you're flying, or is it webinar, or you're flying to Beirut?
I'm flying on Zoom. It's funny because I have a back-to-back meeting, one in Beirut and the next one in Tel Aviv. So which is not, usually it's not that quick. You don't take 2 minutes just to switch from one country to the other.
No, absolutely. The nice thing about these meetings is this the recording aspect of it, because when you have these lectures, they are quite a lot of information, and in the old days, you had to be a Superman to absorb all of it. Now you can really go through it in your own time, very carefully, line by line. So nowadays, these lectures actually become like a textbook chapters, in the sense that they are physical, that you can go back, and really makes a huge difference.
But you were very quick because you already put online the talks from yesterday.
Oh, yes.
Yeah, I was so surprised.
Thanks, thank you. It's easier to get things done immediately. So just we'll give another 2 more minutes, and then I will get to Dr. Lois to introduce you. It was Dr. Lois who suggested the title, Professor.
Yeah, I was wondering. I say, wow. I hope I will answer the question, but I'm not sure.
We'll learn from you, sir. Let's see the time. Okay. So good afternoon from UK, and welcome to everyone to this 3rd day of keynote lectures from both neuro-oncologists and neurosurgeons. And my aim is that we'll have an annual meeting, and this is the program is half neurosurgical and half neuro-oncological. So we have a great program with the legends in the field today. And the first speaker is Dr. Eric Bouffet. I'm going to ask Dr. Stephen Lois, who's a senior pediatric oncologist at the Bristol Royal Children's Hospital, to introduce Dr. Bouffet. Dr. Lois, you just need to unmute your microphone. Steve, can you hear me? I think Steve's computer. I think he's going to relog in. Hello, Steve.
Can you hear me? I'm just trying to. I seem to have a problem with my internet this morning.
Oh, that's okay. Yeah, we can hear you now.
It may just be one of my local internet things. I'll sit in a different room.
Okay, thanks.
Okay, so my introduction to Eric is as a friend who I've known for 30 years. When I first met him, having cycled from London to Newcastle on a steel frame bike with 3 gears. And then he was my mentor in Bristol, teaching me everything I knew about neuro-oncology. He then left and went on to greater things, and ultimately ended up in Toronto, where he has taken a prime role in the whole of pediatric neuro-oncology for North America. And he remains one of the wisest voices and one of the most respected pediatric neuro-oncologists in the world. So you better be a good talk, Eric. We're going to ask you to give a lecture on how to reduce the burden of treatment for pediatric brain tumors. The theme that you have began many years ago, trying to avoid radiotherapy where possible, and I'm sure you'll have an immense amount to say on this subject. So welcome back. Sorry, that was the end.
Dr. Bouffet, you need to unmute your microphone.
Thanks. Thank you, Steve, and thank you, Naren, for the invitation. I didn't know, Steve, that you were behind the title, and I struggled with the title and trying to wonder what I should talk about. So I hope I will not disappoint you, because I took the title from two different aspects. One is from a global perspective, and I'm going to spend quite a lot of time on a global perspective, knowing that there are a number of people in the audience who are from non-high income countries, so country with various resources but essentially limited resources. And I think this is one important topic of how to reduce burden of treatment. And the other one is from the treatment standpoint, is just to say how can we reduce or diminish the long-term side effect of the treatment. And I will take some example of what has been done and where we should go next. So where I come from, first I wanted to explain the first part, which is the low and middle income country story, because I started working with one of the next speaker, Dr. Kadumi, on sort of, this was new to me, this was new to him. How can we work together when the resources are so different? And Ibrahim called me in 2003. He was a young doctor in Jordan, and he was asked to be in charge of a pediatric brain tumor population. And he said, I don't know anything about. So we started to work together. And with this triggered a lot of passion. And I thank Ibrahim for this amazing experience, because eventually, as you can see on the slide, I started to work with a number of different countries, and we have ongoing activity which are not always easy to manage. For example, working with Iran, when you travel to the States and you have stamp of Iran on your passport, it's not very easy, but that's how it is. So, and with this, it was about clinical education and research and trying to teach and to work together. And when you look at the impact, so we had over the years trained a number of different fellows, and in yellow are the fellows who are from low and middle income countries, and really a fantastic experience working together and learning from each other of how to deal with various situations, but also how to challenge the system and the burden of the pediatric brain tumor in these countries, where many people say, so there is nothing to do, we should let them go. And it's right when we look at, you know, the problem around the world and how people struggle with, you know, lots of communicable disease, malaria, pneumonia. We can say that, you know, cancer, and particularly brain cancer, is really nothing. But when we look at the evolution of cancer, of global childhood mortality over the years, we can see that there is a gradual decrease, and with this, an increasing importance of dealing with brain tumors and cancer in general in the pediatric population. And we can see this, and there are slides that I took from from Alan Davidson, who works in South Africa, showing that, for example, when you look at Bangladesh at the publication, when you look at different publications on childhood cancer, the proportion of children with brain tumor is interesting, but sorry, it's increasing, you know, when you look at the first and the most recent publication, showing that it's coming along, and gradually we see that these kids are at least diagnosed. Because the question when you see in low and middle income country, the report on the publication on pediatric brain tumor, you say, where are they? Okay, are they not registered? Because some of the registry do not talk about benign or malignant brain tumor, or they are not seen by oncology service and not registered as cancer in general, or are they just not diagnosed? And I want to show you a map. This is a work that we did the last 2 years or 3 years ago with Kathy Pritchard-Jones, Scott Howard, and Kat Lamb from St. Jude, and looking at the global burden of cancer and how many, what the proportion of children were not diagnosed. And the more red, the more children are not diagnosed. And you can see that in some places in the country, it's not limited to brain tumor. There are many kids who don't make it to the door of the hospital. They die before they are diagnosed. And that's certainly one of the big issues we face, and particularly in the field of brain tumors. So looking at, the global burden of cancer, and we know this, that, most of the cancer are in low income or low and middle income countries, where the survival rate is much lower than in high income countries. What about brain tumors? In fact, when we look at the number of brain tumors, we have the same equation. Most of the pediatric brain tumors are in low and middle income country, where globally it's very artificial. The survival rate is estimated to be around 10%. And why do I say it's artificial? Because many of these children are not even diagnosed. They don't have a scan, they don't see a surgeon, they don't see an oncologist. So we can say that today, when we add up all the information, but still 4 out of 5 children with brain tumor die. And I remember I was, in December 2019, I spent a week at the Black Lion Hospital in Addis Ababa, where I was working with my colleague and friend Daniel Haliu, and it was really, really shocking for me to see that these kids were arriving at the hospital. They were blind. They had tumors that were operated in extremis, and you could understand that many kids could not make it to the door because they were traveling from 600 to 1,000 kilometers away with, their family taking weeks, sometimes months to reach the hospital. And as a result, we know and we witness this in many aspects, that the survival rate of patients with cancer, but in particular brain tumor, is really different between high and low income countries. But the question is, where do we go next? And it's unclear, but to me, it's really, really worrisome that it's likely to be like this. It's not going to improve unless we do something, unless we try to reduce the gap. And particularly at this stage, we thought in the 2000s that we were able to close the gap, and suddenly we had development of molecular biology, new drugs, targeted treatment, and the gap is widening even further. So what is the problem in low and middle income country, and why is there such a difference in the outcome? So one issue here is, when you look carefully, and this is a work that we did with Ibrahim Kadoumi when we started to work together, just to understand what is the difference between your place and my place. And this is listed here. There was essentially no team approach, but also patients were coming late. There was this rule also, which is very common, and that I saw again when I was in Addis a couple of years ago. The VP shunt first, and because of the improvement, then patients were disappearing and coming back, a few weeks or a few months later with diffuse metastatic disease or whatever when it was a malignant tumor. The radiation for most patients, and that's really certainly one of the big issues that we see, and the long interval between all the different disciplines, surgery, radiation, and chemotherapy. But also a cultural issue, which is a lack of trust. So they want to see the local guru. They want to try just some alternative medication rather than to trust the oncologist. And that's really something which needs a lot of work. So to look at this carefully, certainly somebody who has done a lot of work is Scott Howard, who has really looked one by one at the different aspects of the care of children with cancer in general, and how we can decrease the issue or the challenges that we face in the treatment. And it's interesting because it goes one by one, and it goes from how can we diagnose them better? How can we increase the diagnosis, but also decrease the time between the symptoms and the diagnosis? And you have this. I'm happy to share my slide to anyone who wants to have them here. The incorrect diagnosis is a terrible thing. It's just if you have the wrong diagnosis, and I will show you some slides, you have the wrong treatment, and how do you fix this? And that's particularly important in some brain tumor where you have only one shot to cure the patient. And of course, you have the issue of abandonment due to a number of different factors, but essentially, resources, distance from the hospital, and the fact that, you have either a global or public healthcare system that pays for the bill or not. And that's clearly something which is critical in the management of this patient, particularly brain tumor, where it's extremely expensive to treat this patient. And you have also the issue of the toxicity of the treatment. If you give too much chemo and you have no supportive care or no trained team, so that's also going to impact on your outcome. And you have to pick the right protocol for your population in order to give them the best chance of a cure. And of course, at the end, can you avoid some relapses? And that's also something that needs to be looked at carefully. And it's important in every place to have this type of discussion, common discussion between people, and to see how we can interact and critically analyze the situation of patients, not only who have been successfully treated, but also who has failed treatments. And I will go back to a number of issues. So that's a slide from Morocco, courtesy of Laila Hessisen, just showing in patients with brain tumor how long it takes to diagnose them. And you can see that, when you look at this, you wonder more than 6 months or even 4 to 6 months. So many patients in a country which is relatively advanced. In fact, when you go to Morocco, you think that this is not a low-income country. It takes so long to diagnose a brain tumor. But also, once the patient is diagnosed, what happens? Look at this. There are patients who take more than 6 months between surgery and radiotherapy. So where does this come from? Is this from the distance between two hospitals, or what is the reason for this? And in fact, this is where we need to look carefully at what does it mean to, what do we need to treat a patient with brain tumor? And clearly, even in high-income country, when you look at pediatric brain tumor or brain tumor in general, so the management is not easy, it's challenging, because there is a huge diversity of brain tumor, and we need specific resources. Imaging, neurosurgery, neurosurgical equipment, radiation equipment, and the people who are trained and able to do this. And the question is, how can we implement this? How can we do this in low and middle income countries to improve the care to the patient? And of course, we cannot do it with a minimum of infrastructure, imaging, neurosurgery, pathology, radiation, oncology, and rehabilitation. And I will talk about twinning, but I think twinning is a great opportunity here, and it needs to be really certainly developed and organized better than it is today. And we need to have protocol in order to evaluate systematically what is done and how we do. What is the most important message here? Things in pediatric neuro-oncology don't work if we don't bring together the critical partner. And there are the different people here, the neuroradiologist, the neurosurgeon with an experience and awareness of pediatric brain tumor, pathologist with experience or with connection, radiation oncologist, and pharmacist. And looking one by one, so I know a lot of work has been done on looking at neurosurgical availability, and we see such a wide difference between countries to another. And it's clear that this cannot be fixed in one day, but this explains sometimes that pediatric brain tumors are not really a priority when you live in Tanzania or in Malawi. And so this is a work that was done by Michael Dewan, showing the wide disparity in resources regarding neurosurgical resources around the world, and showing that in some places there are so few neurosurgeons that on paper the neurosurgeons should do more than 10,000 surgery per year just to accommodate the need of the population, which is really impossible. Whereas in some countries, you think that neurosurgeons often they have plenty of time to read or to whistle or to play jazz or whatever. But I love neurosurgery. Don't think that I'm against neurosurgeon. But this disparity is the same, I think, in pediatric oncology. And so this is an example of what is needed and what are some of the issues. And I took a few slides, and you will see during my talk similar slide from discussion I had with colleagues and situations that were real-world situation. This is a child with an ependymoma and who got surgery for a large posterior fossa tumor. The diagnosis, this was a 2-year-old child. Grade 2 ependymoma, which means nothing, grade 2, because we know that the grading in ependymoma has no meaning. And he had a large postoperative residue, as you can see here, just on the right CP angle. And the discussion or the question to me was, what kind of protocol of chemotherapy do you think we should take? And of course, I say, this child needs surgery. And the oncologist said to me, no, the child has been sent to me because the surgeon doesn't want to operate again. And this is what we face here. It's just one of the issues. Who decide, who takes the lead, and why do we think that there is no role for surgery? And in this context, the child received 2 courses of chemotherapy, the tumor grew by 50% and was sent to the radiation oncologist, and 6 months later, it was in a palliative care. So this is really, the question is, why do you put so many resources? This child got chemotherapy, got the complication of chemotherapy, got radiation for no use, for no benefit. And you may say, but there may be a few kids who survive here. We know the data. These children, they are PFA ependymoma, they have aggressive ependymoma. If they don't have a full resection, a complete resection or near total resection, their survival rate is below 30% at 5 years. And if they have a large residue like this, the survival rate at 5 years is less than 5%. So do you really need to invest resources in this context when the surgeons say, I will not do a second surgery? And that's the issue is, when do you say no? When do you say there is no need, there is no role, we shouldn't do anything? And that's where I struggle myself, because I think this is not my right to say to the surgeon, you should go there. But this is a role of the team to say, okay, in this context, there is nothing we can offer, we should stop here. Particularly in the context where resources are very stretched. One of the issues I mentioned already is the pathology. And the pathology is really a struggle. There is certainly limited expertise in pediatric pathology or pediatric neuropathology in low and middle income countries. But it's often also associated with limited access to some techniques, even immunohistochemistry, even simple basic, immunostaining. And of course, when we talk about molecular pathology, when we talk about the WHO classification, which uses methylation. So I always joke and say this is becoming a G7 or G20 classification, but not anymore a WHO classification, because nobody can afford the cost of the test except people in very high income country. And even sometimes in a high income country, people say you have to pay to get the result of the test. So what can be done? There are a number of initiatives, and I want to mention some of them because I really admire what people are doing. For example, Tai-Han in UCSF is working with a number of people in low and middle income countries. I've seen him in Morocco teaching pathologists, in Turkey as well. And this is fantastic. He's doing training course, trying to teach the essential of neuropathology. But I want to illustrate what happens when you get it wrong. So this is, there are cases from my video conference, my twinning. So that's a 10-year-old patient, short history of a posterior fossa, MRI scan, had a posterior fossa tumor. If you ask me, I say, this looks like an ependymoma on the scan. And for many of you, it would be the same reaction because the tumor is drooling through the occipital hole, and so you know that this is a classical aspect of ependymoma. But in this context, there was a subtotal resection, a residue, and the pathology was reported as medulloblastoma. And the patient received 36 gray CSI with boost. So you may say this is not really a big mistake, but the pathology review at our institution, when we discussed that, was ependymoma. So the question is there anything you can fix? I would say this is not really the most challenging issue here, because you may say, okay, craniospinal, he got a lot of rad to the brain, but at one stage, this was a standard treatment for all ependymoma. They were receiving craniospinal radiation. It's more about the residue here and how to deal with the residue. But I have seen also the opposite situation where this 8-year-old patient, the MRI scan showed this posterior fossa mass, got a gross autoresection, the pathology was ependymoma, and he got focal radiation. And we say, this doesn't look like an ependymoma, so please send the scan and the pathology. And the pathology review was medulloblastoma. How do you treat then this child who received focal radiotherapy and didn't receive craniospinal radiation? And this is the result of, I don't want to point the finger to the pathologist, but in that case, we say, did you do synaptophysing? And say, we don't have access to synaptophysing. Did you do vimentin? They say, we don't have access to this. And that's why it's very important to teach the basic, because synaptophysing is medulloblastoma, vimentin is more ependymoma. I think you had a talk from Cynthia Hawking yesterday, and she gave you certainly some tips. But that's really some critical aspect. And how do you deal with this? The big issue is there any place, is there any forum where you can discuss this type of situation. And I will work on this and discuss this in a few minutes. So, and then when I mentioned the neurosurgery, you know, when we talk about radiation machine and radiation technique, you see the same trend, the same issue, but there is a wide disparity. The greener, the better, and the paler, the most pale, the worse. And you can see that, for example, in Africa, there have been several papers that have reported the lack of radiation resources in Africa, and showing that, you know, if you don't have radiation, you have limited possibility. And I'm sure that many of you know this paper. I was really, really sobbing when I was in Addis, but they were about to start to work on the first LINAC when I was there in 2019. But this was the only machine that they had in a country for a country of 100 million people. So how do you deal with this? How do you manage patients, and in particular kids, who may need, for many of them, sedation for their treatment? And what about medical oncology? So the medical oncology, you need a number of things, not only antineoplastic drugs, but all the medication that go around the management of these patients: steroids, anticonvulsant, pain medication, and of course, you know, the supportive care, antibiotics, antifungal. And when you are in countries with parasitic disease, so all other medication that's maybe not affordable or not available. And of course, the issue of blood product is a very, very big challenge. And one other challenge is certainly the issue of fake medicine that we see increasingly. And I remember when the embargo started in Iran, the Trump embargo, so there were suddenly short of resources, particularly asparaginase for leukemia, and I was working with them, and you know, the number of times we had to deal with fake medicine or cheap drugs that were coming from different places in the world, but were certainly not, you know, approved or WHO certified, was absolutely unbelievable. So that's one of the issues we face in these countries. So what are the main challenges when we look at this? So how can we fix it? And certainly one of the issues is the multidisciplinarity. How can we make people work together and put in place a system where every patient is discussed and is a center of attention, and improving communication when the patient needs more than one treatment. And so when we look at this, when we dissect, and I remember I was part of a work in Algeria in 2003, just with the government, looking at the different services, and really everybody was doing a great job. But all together, when I was looking at the data I had, there was a 1 to 3 months gap between every step of the course. And really the question was really, how can you change this and how can you make things happen? And certainly I like this flower because it really illustrates what the patient needs. The patient needs, you know, all the petal of the flower. He needs everybody to take care of him. And if you want this to happen, you need to have a driver here. You need to have somebody who is making sure that everybody is involved. So in some places, this is a neuro-oncologist. That's a sort of Western type model. In some places, this is a radiation oncologist. So for example, in India, that's often the case. It was the case in the UK a few years ago, and then progressively, pediatric neuro-oncologists became the primary driver. And in some places, particularly in some Asian countries, it's a neurosurgeon. So maybe good, maybe bad. I was always wonder when the neurosurgeon is for 12 hours in the OR, can he has the time just to take care of the patient? I'm not sure, but I'm not convinced. And I still think that the neuro-oncologist certainly has the best availability here, and particularly in the long term. But regardless, if you don't put in place this multidisciplinary collaboration, if you don't bring people together, this is what happened. The patient is left alone, and there is absolutely nothing that is going to work. And this is why you need to have people who meet together and talk together about how to best take care of the patient. And so that's where the story of twinning is certainly, for me, a passion and a way just to figure out how to make this happen, even in countries with limited resources. And there are a number of examples where it has been successful. That's the work for Narenthiran, who is now just working with industry, but for many years has been working with 57357. And I know that you had a talk by Mohamed El-Batagli yesterday, and Mohamed has been working with Mark for so many years. This has been a fantastic collaboration. You have the work in Paraguay that was led by Jonathan Finney and Alvaro La Saleta. Fantastic work where they put in place a pediatric brain tumor program nationally. And, you know, that's the work that we started with Ibrahim, and we started with email. I tell you, I was receiving 2 or 3 emails per day for 1 year before we started to do the teleconference. And the first teleconference with Ibrahim was to discuss a complex case. At the time, the phone was very expensive, so we decided to figure out how to make this happen. Initially, we started the conference on a Friday morning, and it was only 2 of us. But eventually, Ibrahim was able to bring the team, and I was able to bring the surgeons. So that's Dr. Peter Duggs, and there is Dr. Drake also, and we were able to discuss. That's 20 years ago, and you can see the quality of the picture was quite good. We could discuss not only medical treatment, but also surgical treatment here. And so we wanted to share this experience. We published some of the data, and clearly showing that it makes a big impact on the management of the patient, but also on the teamwork. And that's an illustration of how we were able to decrease the interval between surgery and radiation. That's the first publication at that time, so I know that the result eventually changed and with a lower survival, but the survival of average risk patients with medulloblastoma was quite spectacular after we started, and they never had seen this before. And so we continue this twinning program for many years, and it's still continuing today, nearly 20 years after. But what we can see is that we see a gradual change, and the discussion leads to less changes. Initially, nearly half the cases discussed, there was a big change, a major change in the management of the patient. And over time, you can see that there is a gradual decline, and today it's around 10%, but it's still something that we find it very useful, and particularly for the training of the next generation as well. That's very important, including on our side, in fact, the training of our fellow who realize that, you know, neuro-oncology practice in high-income country is not everything. I started a few years after to work in Pakistan, and that's Noreen Mushtaq, who was working with me. And this is also an amazing experience, which is even more impressive when you realize that in Pakistan, you have around, we think, every year, 3,000 cases of pediatric brain tumors. So a population of 60 million kids. And I went there in 2018, but initially we started just to work remotely. And this is really something which is going on where we spend a lot of time, and we got also support. We got a grant to try to improve the setup nationally. So how does it work? We have regular meeting once a month. It's 1 hour to 90 minutes. We have a video conference every time, and we discuss 4 or 5 patients per hour. They present, we discuss the pathology. Sometimes we review the pathology sample at sick kids. It has a cost. We need to find funding. It's sometimes a struggle. But at the end of the day, so this was also something which was great. We were able not only to bring some patients from the local hospital, which is Aga Khan University, but also from other hospitals, and that's Indus, which is a large public hospital. Aga Khan is more a private, semi-private institution, and also hospital from other places in the countries. So really the impact of this in Pakistan, that's a slide from a few years ago. There is a paper coming up in Pediatric blood and cancer in a couple of weeks, which shows the global impact, but it increased the number of patients referred to both institutions. It increased the quality of the care. I tell you, I was there in November. It's absolutely phenomenal to see how wonderful work they are doing. And we were also able to develop standard protocol for a number of different diseases. And that's very important because that's how you can really streamline the treatment and make sure that patients are treated appropriately after careful discussion of the situation. Zoom, I hate Zoom, but this is a beautiful tool because you can see that now our conference are attended by many different groups from around the world, and it's increasing. I can see now some conferences we have people from 20 different countries, either presenting cases or just learning from the interaction we have. And that's really a very good tool for, teaching and collaboration. So what we are trying to do as well is to bring people to Toronto and to teach them of how we work together, not only to teach them the high-income country way of doing things, because this would be useless, but it's just to review the protocol, to discuss and to discuss more the organization of the care. So for this, we have a sort of small fund where we support the cost of the people. We have brought people from many different places, as you can see, and this has been really, really a wonderful experience. It's not limited to sick kids, and I think Daniel is going to talk about this later on today, but he has developed an absolutely spectacular system and course of pediatric neuro-oncology at St. Jude. And this is another way of teaching people, bringing them and trying to make sure that there is a relationship that is going on also in the long term. But the work from Daniel and Ibrahim, I think, who are going to talk later on today. The question is always, when you do this, how long should you do it and whether you should stop one day? And I'm still unsure of this. I have to say that I'm still passionate about when we have our meeting with Jordan. Now it's not Ibrahim anymore because he's at St. Jude. This is Nisreen. And I always love this time. And I think we are always learning from many things. And the impact on the side of the people who are doing the twinning is difficult to assess because they don't always have the tool or the registry. We are trying with Jordan and Pakistan in particular to have more and more data, and that's quite spectacular when we see the impact in the long term and the outcome of the patient. And we have published this, and we are trying just to publish from time to time. In fact, what we are trying to do also is to try to bring new techniques to their country. And for this, for example, we got with Nisreen Amirari from Jordan an ASCO Fellowship Award where she came to Toronto and she did work on the subgrouping of medulloblastoma and how we can implement technique in low and middle income countries. And this was published last year in Journal of Global Oncology, just trying to share some of the experience and some of the knowledge that we have in low-income country. With this, we certainly have collaborated and done a lot of research. And one of the research I want to mention is the back the give and take. So the people from Jordan and Pakistan have taught us a lot about this condition called mismatch repair deficiency and ultra hypermutant cancer. And this is a work that was conducted by Uri Tabori. And that's based on the evidence that their NF1 population was not the same as us. And in fact, they were not NF1 patients. They were patients with cafe-au-lait spots, but they were patients with another condition called mismatch repair deficiency. And that's how we started to work on this. And the impact has been huge on our side and on their side. And what we are trying to do now is to implement protocol in their country to bring the drug, because with this, we were able to demonstrate that the patient who have this tumor, that's a patient with a multifocal relapse of a glioblastoma. Usually you expect the survival to be 3 months when you have been irradiated and you have multifocal relapse. This patient survived 2 years after, just treated with nivolumab. The brother lived for 5 years after that and died of second cancer. And we have published last month in Nature Medicine the long-term result of this on over 50 patients treated with immune checkpoint inhibitors, showing how much benefit they can have from this type of approach without using, in fact, radiotherapy or chemotherapy, because they have very, very specific profile. So in this context, Uri has built a consortium and which really brings together people from not only high-income country, but as you can see, also low and middle-income country, particularly country where there is a high rate of consanguinity, where the incidence of mismatch repair deficiency is relatively high. And this is a great collaboration that is going on. I have to say, this experience of twinning is also the opportunity to bring to this country that normally have no access to drugs, some drugs that would be only available in our places. And we were able to develop a compassionate access program with Jordan for BRAF inhibitor, with Pakistan as well. And as I mentioned, my dream and my work today is to try to bring immune checkpoint inhibitor in this country, because they have many, many more patients than we have. The other way that we can also decrease the burden is just by bringing the kids earlier. And certainly one of the pioneers here is David Walker, who has done a great job with the Head Smart program, showing that with a simple tool, simple information package, you can have an influence by working with the GP here. And David just brought this very simple thing. And of course, this was in a high-income country. David was able to measure the impact of this by looking at the national informatic system. But we say, why not in a low-income country? And that's something we started to work on when there was 3 years or 5 years ago, a call for application from Sanofi Espoir, which is a private NGO that is funded by Sanofi. And we use this call for application to have a global mapping of oncology service with SIOP. At that time, I was SIOP president. But with Jordan, we put together a project for early diagnosis of brain tumor. We translated all the tools from David with his permission in Arabic. And this program has been absolutely phenomenal despite the COVID pandemic. And this was completed a year ago. And we are now looking at the data, and we can see that there has been a huge impact, bringing the kids to the hospital much earlier than it was before. We also use this opportunity to put a bid for the building of a national pediatric neuro-oncology network in Pakistan, and this was led by Noreen Mushtaq. Again, a phenomenal experience. Now there are 13 pediatric oncology centers in Pakistan that have a multidisciplinary pediatric neuro-oncology program, when there was only one in 2014, that's Hakan University, and 2 in 2017 when we started this project. So now is for Steve, because he said, how do we reduce the burden? So I want to talk about a real world experience, and particularly in medulloblastoma, because that's really the typical example of a topic where in infant we struggle and we don't know what to do. We have this tool, which is, I call a kiss of death, which is radiation treatment. And when we look at the first baby brain protocol, this was in the 80s, they all had a similar design. And this was surgery followed by chemo and radiation at the age of 3. You had this sort of graduation ceremony where you were 3, you had to meet with the radiation oncologist to have your brain irradiated. And in fact, this is very important to remember that we have to forget this. We have to forget. And I don't know why, but people still have in their mind the fact that, oh, the child is turning 3 tomorrow, I need to send him to the radiation oncologist. It's really something which makes me sad, because I still practice in many, many places, including in some high-income countries. So what was the result of this practice? So patients, because they were diagnosed at different time of their infancy, were treated for a longer or shorter duration. And the paper that was published by Paediatric in 1993 in the New England Journal of Medicine reported the whole series of medulloblastoma, ependyma, PNET, brainstem glioma, etc. But when you look at how they were just treated, they were treated with chemo, and then they were receiving radiation according to their initial staging. So which means some of the kids were receiving very high dose craniospinal radiation. When we look at the outcome first was different according to the age. It was lower for the patients treated at a lower age, and it was higher for the patients who were diagnosed later on in life. But when you look at the progression-free survival, it was in the range of 30% for the younger, in the range of 40% for the older, despite the fact that they were all treated with radiotherapy at one stage. So first, not as good as we could see in older patients. And so that's the overall survival, the progression-free survival that we could see in this context, and the overall survival, which was around 40 to 45%. So the lesson from this was the median progression time was short. Many patients were progressing early. The survival rate was lower than in older children. And the best results were in children with non-metastatic disease and a good resection. But several children, and that's something we learned from this, several children who did not receive radiation because the parents say, no, we don't want radiation. You told that this was bad. Several children who didn't receive radiation did survive. And this is what we learned from this. But there might be some children who didn't need radiation. And the question was, who were they? And the second lesson was children who failed chemotherapy or children who received radiation and survive, what was the cost? And there was no specific study in the baby POG1 protocol, but there were in parallel a number of studies that were done that looked at this. And when you give radiation at the age of 3, which is what Walter and the people from St. Jude, Amar Gajjar reported in 1999, they looked at patients 5 years after the end of the radiation when they were treated during their early childhood. And you can see that their IQ was on a range of 62, which means 62, you cannot read, you cannot write, you can only just live. You have no job. So that's what happens when you give radiotherapy at the age of 3 to a child. So with this, you need to make a decision. Either you continue to do this or you change the rules. And in fact, changing the rules has not been easy. And there are, as I say, many places where people still do this. And subsequent protocol, people try just to change and say, let's drop the radiation, because it seems that some kids do well without radiation. This was done in many protocols. particularly in this protocol called 9921. And the outcome of 9921 were, when you do this, only 20% of the children, there were nearly 100 children with medulloblastoma here, only 19 made it to 5 years without radiation. So 20% success rate, not a great success. And this was the case until 2005 when Stefan Rutowski published the work that he had conducted with Joachim Kuhl. Joachim Kuhl was his boss. He unfortunately died of glioblastoma 2 years before this publication. But this work has been absolutely spectacular. And this was the use of a short course of intensive chemotherapy with a backbone of methotrexate and the administration of intraventricular methotrexate during the time of the chemotherapy. With this, Stefan showed that the survival rate of infants with medulloblastoma treated without radiation at 5 years, when they had complete resection and no metastatic disease, was absolutely phenomenal, 82%, lower when they had residual disease, and not good when they had metastatic disease. He was also showing that the IQ of these kids was much better when they were treated without radiation compared to the patients who were treated with radiation or salvaged with radiation. Not as good as normal children, but certainly better. And in addition, the IQ was sustained over time. It was not declining as you see over time when you use craniospinal radiation. And the fantastic thing that Stefan did was to look at the histology and reported that, there was a group of children, there were half of the kids in this experience who had the desmoplastic histology, the nodular aspect in their tumor, who were doing fantastically well, 85% progression-free survival. And so the desmoplastic is really one of the characteristics of half of the medulloblastoma in infancy. So when the Germans were doing this with standard chemotherapy in North America, people were more interested in high-dose chemotherapy using a protocol called 99703 or SCNS 334. They didn't show any difference in event-free survival or overall survival compared to the German study, but they also confirmed that desmoplastic patients were doing much better. And so the question is, where are we now? And in fact, that's an interesting topic because the Sanjut group started to challenge the use of intraventricular methotrexate with a protocol that was using only systemic chemotherapy with some maintenance treatment. And look at what they reported in infants with medulloblastoma. A survival, a progression-free survival that was really, certainly different from what was reported by the German group. And really, when you look at the desmoplastic, the classic and the large scenario plastic, and you compare this with the HEAT protocol, it's really different, suggesting that the intraventricular methotrexate is critical here. And this experience has also been confirmed in another protocol that was conducted by the Children's Oncology group, where we only enrolled desmoplastic patients. They were treated with exactly the German protocol, but no intraventricular methotrexate. There were very strict stopping rules, and this is what happened. So patients did well during the chemotherapy, and suddenly we saw a drop in the progression-free survival with half of the patient progressed. Fortunately, we were able to salvage most of the patients, but with the use of radiation, there was some additional study that was done that identifies two subgroups of sonic hedgehog. I will not comment more about this. And also some additional study that show that patients with extensive nodularity did very well, as did the youngest patient, who were less than 1 year at the time of diagnosis. And so this is the illustration of one of the child who was treated in this protocol. And you can see that when you want to reduce the burden here, you don't want to send this child to the radiation oncologist. This child is absolutely normal, was treated for a desmoplastic medulloblastoma, a classical sonic hedgehog, and is now a normal child going to school with a normal IQ. So the message here is we have a high cure rate in 50% of infants and young children with medulloblastoma. They are desmoplastic. We don't need sophisticated treatment. Of course, in this context, desmoplastic histology is critical. And even in this, surgery is not a prognostic factor in desmoplastic. You can leave a lot of tumor behind. It's not going to impact on survival. The question is, can you do anything else than intraventricular because people have an Ommaya reservoir or Rickham reservoir? It's not clear. We are working with people in low-income countries just to see if intrathecal is the same. And there is no need for radiotherapy. There is no graduation ceremony. They live and they have a normal life. So another thing I want to say about reducing the burden is to look at other long-term complications. And I want to value and to applaud the work that was done by Pepe Brock on sodium thiosulfate in hepatoblastoma and say, we need to do the same here in kids with brain tumor, because one of the second most concerning complication is hearing loss when they receive chemotherapy. And we are trying now around the world to implement protocol with the use of sodium thiosulfate in order to preserve or to reduce the hearing loss. So I will finish this. I know that I was very broad, starting in low-income country and then taking this example of the medulloblastoma. I could talk about ependymioma, I could talk about low-grade glioma. But I think the most important is to make sure that you implement multidisciplinary work. But this is a complex discipline, you need dialogue. Knowledge is important, and that's where twinning may bring some knowledge, because we discussed recent paper. Twinning is helping, but there is no reason today to think that neuro-oncology is a privilege of rich country. It can be done anywhere as long as you have limited the resources that are needed. The rest is a matter of, you want to make it happen and it happens. And the example of Pakistan, Jordan, and many other countries is an illustration of that. And in this context, I want just to mention that the Global Initiative for Childhood Cancer has, thanks to the people from St. Jude, I think particularly Ibrahim Kadoumi, has included low-grade glioma in the target tumor. And this is an initiative that is targeting to have a survival rate of 60% in this country with limited resources by 2030. So it's an opportunity for pediatric oncology, neuro-oncology, to be part of this initiative and to make sure that we can work together to make a difference. I want to finish and thank all my friends and colleagues, but also just spend just a minute and to share my thoughts about what's going on in Ukraine. So this is Roman, who is my friend. He's a bit of my son or spiritual son there. This is something that he was interviewed yesterday by an Italian journal and telling that he will stay here and he wants to continue to do his job for his patient, because his patient are a priority. And I want just to really applaud his courage and the courage of his colleague in Ukraine. Thank you very much. And I'm happy to answer any question.
Thank you very much, Eric. As ever, you have stated given a lot of wisdom in a relatively short space of time. If anybody wishes to ask any questions, please put them into the chat box. We don't have any specific questions at the moment. If I might just comment that the conversations we've had over many years have been along the themes that you've talked about. The work that you've done in low and middle income countries is really quite remarkable. And I wonder how other countries can expand this facility. Places like St. Jude's, Toronto Sick Kids, you are very well resourced and you have the facility to make contact elsewhere. But I know that my colleagues in the UK have done limited communication with other countries as well, particularly people like Simon Bailey in Newcastle. And these have been very successful programs, and I wonder if we could maybe encourage everyone to think how we could go back to our own centers and do the same.
No, I agree. It's time consuming. You have to do with passion. Simon has a passion. Barry Pizer has a passion. There are people like this. It's part of our genetic material, perhaps. I want to say that my passion is so big that I have decided to step down and to spend now my time to work with low and middle income countries, and because I think there is so much to do there, and particularly with the development of or trying to bring some of the new drugs to these places. And I think this is possible, but it's only going to come if people like myself or other people who have interaction with drug company can convince the drug company to bring their medication to this country. It's heartbreaking to see that we have access to, let's say, entrectinib or drugs like this that are revolutionizing the treatment, and you identify an NTRK mutation in a child in Pakistan, you say, there is nothing I can do. I cannot bring the drug. So that's also something that we need to do together.
Indeed.
Steve?
A request from Dr. Gupta asking if we could talk a little bit more about the observership programs. I'm sure that's a conversation that go on for some time. Is there a way that people can contact you specifically about that, or is there another route?
So the observership first has been on hold for during the COVID. It has been, a sort of nightmare. But we get requests from around the world. They know it's just a word of mouth. I use also Concept Point, which is a website of Pediatric Oncology, to advertise, and the requests come. We select the requests according to the interest of the people. And then we organize everything, passport, and the flight and accommodation in Toronto. They spend 4 weeks. The 4 weeks are divided in two. The first 2 weeks, they just shadow us. They spend time with us. They see how we work. They are often a bit lost because they are not often used to the intense rhythm that we have, seeing patients, going to meetings, etc. But after 2 weeks, we start to organize interaction between the different provider of care, just to make sure that they have time to discuss and meet with the people and understand how they can integrate this profession in their own practice. And the last week is essentially a week of discussion, interaction, review of the protocol. So it's very intensive. We don't want to have it longer. First, because this is very time consuming for us. We have 2 observership per year on average. And also we don't want people just to stay for staying. So it's very dense, very condensed. This is something I started with Ibrahim Kadoumi, and we decided just to perpetuate this. As I say, the budget is not a big budget, so it costs on average $10,000 Canadian per year. And that's very, very rewarding.
Thank you.
Steve, is it okay if I invite a few of the panelists to have their comments or from their perspective? Is that okay, Steve?
Yes, sorry, as we're over time.
That's okay. Dr. Cohen, do you have any thoughts on whether neurosurgeons should join something similar to that, or whether we are too busy for these training programs?
Well, I don't think anybody's too busy for our patients, and I congratulate you, Naren, again for these courses that you've put on that make the world a smaller place, and to Eric, who's actually taken the advances from the ivory tower and brought them to the world that we have now with next generation sequencing and all the advances in molecular biology, the ability to really target some of these tumors in ways that we couldn't before. And as Eric pointed out, this technology is not available worldwide, and even in the United States, it is expensive and delayed, and we have to try to figure out how to bring this technology that we have to the rest of the world. And I think Eric's work is a great example of that.
Thank you. Can I ask you, Dr. Bouffet, a question myself? The thing is that in terms of twinning, how do you manage to choose the right partner? Because you want to have a department that has enough resources to give some basic neuro-oncology service, but in the same time, you don't want to partner with centers which are, have good resources or more private. How do you balance that that twinning program, that it's actually the ideal partner for the twinning?
Yeah, so that's a good question. So it has been more or less natural, but also opportunity. People who approach me, I met, it's often because of sort of connection which happen. Okay, it's the friendship. The connection I have with Roman, it's just like from a dad to a son. So it's just like this. So Roman came 10 years ago to me and said, can you help me? And, we have this very, very close interaction, very close friendship. The same with Ibrahim Kadoumi when we started in Jordan. The connection I have with Nisreen or Noreen is also respect and friendship. It's also just evaluating the resources and what are the needs, but what is the enthusiasm? And one difficult aspect is it's not limited to the neuro-oncologist, it's also to the partner. And certainly the neurosurgeons are critical here. I have really the privilege in Toronto to work with great people, and in particular, Jim Rutka, Jim Drake, and Peter Dirks, who are passionate about this. And Abaya Kulkarni is coming in as well. And so that's also a plus, because they come, they attend. It's even much easier now with Zoom, because often they don't have the availability to come to the same room. But and then they join and they comment on the surgical aspect. And by being here, it also brings the surgeon from the other side. So that's where it's critical. If you don't have the different member of the team, it may be one of the limitations. You cannot build the multidisciplinary approach on the other side. And we were very successful here, particularly in Pakistan, where the neurosurgeons are very much coming in, and this has made a huge difference in the practice.
Thank you, Dr. Bouffet. We have got, at least I know, 2 neurosurgeons here who work in developing countries, Dr. Dieter Klaas, who goes to Cameroon, and Mr. Shalendra Magdum from Oxford, who does go on the MRCSE ship. Dr. Klaas, do you have any comments on having been to Cameroon? What kind of neuro-oncology services there? Is there any option for these twinning in those countries?
Well, thank you, Naren. It's still a very long way to go, and the political situation in the country right now is really very hard to understand. The quarrel between the French part and the British part is really a nightmare. So everything is developing very slowly. They are building up a program in Bingo in the Northwest region, but it's really only in the beginning that the work is for the moment. I admire very much the talk of Dr. Bouffet, because it was really opening our eyes for the true problems we are facing, especially our thinking about the WHO classification of the tumors, which refers to the G7 and G20 countries really. And I think we always have to keep in mind that we are in a very privileged situation, really. And coming back to your original question, in Cameroon, Naren, it's still a very, very long way to go. People with children with brain tumor often go to Kenya, to South Africa. Some are operated in the country itself, but there are many, many children suffering still. That's right.
Thanks. Dr. Shalendra Magdum, do you have any thoughts from your experience in Africa?
Thanks. A great talk, Dr. Bouffet. And similar to you, Vince, I kind of find 2 things. If your talk has given me some insight about working in Africa in at least 5 countries on the western side and being in Madagascar for a period of time. It's 4 neurosurgeons for the whole of country of Madagascar. Cameroon, similarly, I met 3 of them. And again, as Dr. Dieter said about the French and the English conflict going on there, it's difficult. Most of these guys get medical degree from Russia, and they have got about 6 months, 1 year fellowship in a Western country, mostly because of the French-speaking areas. They go to France and they come back and start operating, and basically don't think they have got the equipment. But one of the best positioned countries in this area is Senegal, who can be the hub and spoke model. So if you can as a society or former society, and probably tie up with Senegal, who had the biggest unit, plus the amount of female neurosurgeons in that unit, I've never seen even in Western countries. So that could be the one where you can. Now, what is happening is Toronto is doing this job for a few countries, but Toronto can't help everyone. So if Toronto helps one country, like going to Senegal, Senegal can help 10 different countries, because I saw in the Senegalese program that they had at least 15 different neurosurgeons from 15 different countries training there. So they are the Africa's sick kids, or gosh, we should basically tell them that this is how to do it, and they can then propagate that. That's my thought.
Thanks. Thank you. Thank you, Dr. Chandra. Professor Bouffet, do you have any comments on that?
No, I was not aware of Senegal. I know the School of Neurosurgery in Morocco, but it's a phenomenal training place. I've met a number of people. There is also the this organization called GFAOP, which is a Group Franco-Africain d'Oncologie Pediatric, the Franco-African group of pediatric oncology. And that's where certainly Francophone Africa can do something in the field of pediatric brain tumor. I know this has been relatively weak. They have done most of work in Wilms tumor and Burkitt's lymphoma, but I know a number of people, for example, Nicolas André in Marseille is working, and we are trying just to make effort to improve the visibility of neuro-oncology in this context. And I hope that we will work closely with Cameroon and with other countries. As you know, it's certainly easier to be Canadian than to be French now in this part of the world, because there are tensions. That's also another problem. Is, you know, what we see in Ukraine now is something which can happen everywhere, and some of the initiative collapse suddenly because of political issues.
I think if you look at the stability, political stability, Senegal is the most stable in the West Africa. So that is why I think it's a very good place. And I went to the department, I gave a couple of lectures there, and they have got very good system with 4 professors, the 3 running OTs, and they're doing most of the stuff which we would do with endoscopes and everything else. So I think it's a very good opportunity.
Thanks. Here we have got Dr. Mette Jorgensen from neuro-oncologist from pediatric neuro-oncologist from Gosh, Great Ormond Street Hospital. Mette, do you have, I know you guys are very busy with a large tumor practice. In terms of, do you have any outreach programs, or do you have any plans for outreach programs?
Not that I'm aware of at the minute. I know that some of the consultants are individually doing that, particularly around retinoblastoma specifically, but sadly, I don't think we have anything at the minute.
Thanks. Thank you. Thank you, Mette. We have got Dr. Suhas from India, Suhas Udayakumar. Dr. Suhas, in terms of the chemotherapy in India, is it the same? Do you have any local low-cost provision, or do you buy it once again at high price?
Hello.
Hello, Suhas. In terms of the price of the neuro-oncology or neuro-oncological medications, how do you guys fund it? Do you get Indian-made medications, or do you have
no, we don't have issues. We don't have issues.
In terms of the pricing,
No issues. No issues.
Okay. In terms when you say no issues, you mean that you have got the prices are affordable in India, is it?
Yes. Okay. Yes.
Is this because locally produced chemotherapies, is it?
Yes, we have. Yeah. We have more subsidies now for chemotherapy medication.
Okay.
So we have no issues now.
Thank you very much.
Thank you
very much, everyone, who commented. Thank you very much, Steve, for taking Professor Bouffet's lecture and suggesting me and supporting me for this day. So now we are going to go to Dr. Alan Cohen's lecture. I'm just going to make small changes on the computer setup.